Next, we're going to be looking at patterns of neuronal activity. So when it comes to brain functioning, this involves continuous electrical activity of neurons. You can measure this electrical activity in an EEG or an electroencephalogram, so it can record aspects of brain activity. Now, these patterns of neuronal activity are recorded and called brain waves. And this generated electrical activity is actually occurring at the synapse. So this is not looking at action potentials. And each person's brainwaves are unique, so they can be grouped into 4 classes, but are ultimately unique. And they're measured as hertz. The brainwaves that the 4 classes that we're going to see are alpha, beta, theta, and delta waves. Now, for alpha waves, what we're going to see is kind of these small little waves that are close together. But this is awake and relaxed, so they're not quite as close together as what we will see for beta waves, which is when someone's awake and alert. The waves start to get a little bit deeper when we see theta waves, which are more common in children, but you might see them in adults when they're concentrating, and they're kind of the deepest and kind of more spaced out when we go into delta waves, which is deep sleep. We also see delta waves when the reticular activating system is dampened, or when an adult is awake but has brain damage. So why would we even look at brain waves? Well, they do change with age, sensory stimuli, brain disease, chemical state of the body. So we can use EEGs or electroencephalograms to diagnose and localize brain lesions, tumors, infarctions, infections, abscesses, and even epileptic lesions. So, for example, you can evaluate several types of brain disorders because when epilepsy is present, the seizure activity will appear as rapid spiking waves on the EEG. Or if someone has a lesion on their brain, or a tumor, or a stroke, they might have unusually slow EEG waves. So it depends on the size and location of the lesion or the stroke. So we would use this for diagnostic purposes. And a flat EEG has no electrical activity, and that would be the clinical evidence of brain death. So let's talk more about epilepsy. It is a homeostatic imbalance, and it's an abnormal discharge of brain neurons. Now, it's never associated with, nor does it cause, intellectual impairments. Instead, a victim of epilepsy may lose consciousness, fall stiffly, have uncontrollable jerking. Those are all characteristic of epileptic seizure. And that's because of this abnormal firing of brain neurons. And it only occurs in about 1% of the population. Now, there's 2 main types of epileptic seizures. There's formerly what's called petit mal, which is now called the absence seizure. These are really mild seizures seen in young children where the expression might go blank for a couple of seconds. Then grand mal seizures, which is probably what most people picture when they think epilepsy, where the victim kind of loses consciousness, drops, they can break bones, they can bite their tongue. It also can be quite embarrassing because they might lose their bowel and bladder control, and they might severely damage parts of their body. Now, to control it, there are anti-epileptic drugs. There's surgery to remove a small part of the brain, and that's more common for focal seizures. There's also a vagus nerve stimulator or a deep brain stimulator that can be implanted, and it delivers pulses to the vagus nerve or directly to the brain to stabilize brain activity to help reduce that abnormal brain or neuronal firing. There's also research into brain electrode implants to detect and prevent oncoming seizures, because currently a lot of the vagus nerve stimulators actually have kind of a button you press through the skin, and those individuals with these stimulators would press the button when they have kind of an aura, which might be the smell of rotting meat, or it might be kind of lights they see that usually tell them they're about to have a seizure. Now, we can also talk about levels of consciousness, because that encompasses things like perception and voluntary initiation or control of movement, and whether or not you're capable of higher mental processing. So when we're talking about consciousness, we're not necessarily just talking about if someone's awake or asleep. They might have a brief loss of consciousness, like fainting or syncope. They might be in a coma, which is an extended period of loss of consciousness. But there's actually clinical levels to consciousness, like alertness, drowsiness, stupor, and then coma. So when we talk about sleep, we are talking about a partial unconsciousness, but a person should be able to be aroused by stimulations, should be able to be woken up from sleep. There's 2 major types of sleep, though: non-rapid eye movement, or non-REM, and rapid eye movement, or REM sleep. And generally you go through 4 stages of non-REM, and that's about the first 30 to 45 minutes of sleep. And then REM sleep occurs after the fourth non-REM stage has been achieved, and most dreaming occurs here, and we'll see waves that are very similar to the alpha waves of the awake state. So you can see the alpha waves of the awake state, really similar to those REM sleep waves, and that's when skeletal muscles, except for your ocular muscles and your diaphragm, are actually inhibited. So even though most dreaming occurs here, most people don't act out their dreams. And this is also why we see the name REM, or rapid eye movement, because your ocular muscles are not inhibited and move about. Then you have non-REM stage 1 through 4. Note that the waves get quite deep. If anyone has night terrors or sleepwalks or bedwets, that generally will occur during non-REM stage 4 right before they enter REM. And we know that sleep is important. It's presumed to be a restorative process, especially reaching non-REM stages 3 and 4. And a lot of nightmares and night terrors occur here. But if you don't leave those stages and move into REM sleep, you might become moody and depressed. And REM sleep, we think, is a reverse learning process, so kind of a letting go of kind of superfluous or extra information from the brain. And daily sleep requirements do seem to decline with age, but that may actually be representative of disordered sleep, which is much more common in the elderly. All right, stages of memory next. We've already talked a little bit about memory, like that of the hippocampus and where long-term memories are stored. And your long-term memory is actually limitless. It may not seem like that, but your short-term memory actually only lasts seconds to hours and can only hold about 7 to 8 pieces of information. Short-term memory is called working memory, and it's supposed to be fleeting. So it's supposed to hold things that continually happen but are not super important. So even though it may not seem like it, your long-term memory can hold a lot more than you think. All right, next we're going to be looking at the protection of the brain. So we're going to kind of shift focus away from the brain itself and look at what's around it, and then we'll look at the spinal cord. So make sure to watch that video as well.